Hi, everyone, and welcome to the Leong Center in Child Health Evaluated Sciences rounds. My name is Priscilla Medeiros. I'm the Knowledge Mobilization and Community Engagement Specialist at the Center and your moderator for today's session. We are delighted to welcome Dr. Ashley Vandermorris, staff pediatrician in the Division of Adolescent Medicine at SickKids and a member of the SickKids Centre for Global Child Health and the SHARE Project youth researchers to the event. So the center is certainly committed to enhancing the capacity of its members to work collaboratively on youth participatory action research for the mutual beneficial exchange of knowledge and resources. So we are excited to welcome, as I'd mentioned, Dr. Ashley Vandermorris and the SHARE Project youth researchers to discuss today, first, how adolescents' experiences of sexual and reproductive services have been impacted by COVID-19, and second, what are potential policy and program solutions to address and enhance adolescent sexual and reproductive health and rights? I'm certainly very excited for today's session and to engage in a larger conversation with all of you during the Q&A portion of this event. I'd like to now hand it over to Ashley and the rest of our speakers.
Thank you so much, Priscilla. I'm just going to share my screen so So thank you all so much for joining us today. It is my absolute privilege to open today's session on behalf of folks from a number of institutions that are seen here at the bottom of the slide, who all came together to collaborate on this project, Sexual Health and Reproductive Empowerment, or the SHARE Project. So our hope for the next hour is to present a little bit of a background of the study. We'll review the study design and the two phases that this study involved. We'll spend the majority of the time, which is what I think most of you are here for really, to hear from our youth researchers about their youth-led research projects. So each team will speak for 15 minutes, for 10 minutes, and then have 5 minutes of Q&A after their presentation. So we'll let you know when that Q&A is open for each of the groups. And then at the end, if we have time, I'll pop back on and just speak briefly to some next steps for SHARE. So the formal title for this research project was Exploring Inequities in Adolescent Sexual and Reproductive Health and Rights in Ontario during the COVID-19 pandemic. This study really emerged out of our awareness of the ways in which COVID-19 may be intersecting with adolescent experiences in a number of domains. So we know that COVID-19 has negatively impacted aspects of normative adolescent developmental trajectories, things like the nature of peer relationships, parent-teen dynamics, opportunities for emerging autonomy to be built on and developed. We also are aware that COVID-19 and its associated public health restrictions have led to reduced opportunities for comprehensive sexual health education that is typically delivered through schools. We know that in other contexts, COVID-19 has limited or altered access to confidential sexual and reproductive health, or SRH, care, medication, and services. And we also know that COVID-19 has further exacerbated existing inequalities and widened health inequities for structurally marginalized populations. So out of this awareness was born really two research questions. The first was, what are the effects of the COVID-19 pandemic on rates of pregnancy and sexual and reproductive health care utilization among adolescents in Ontario? And are there inequities in these effects? And the second question was, how are adolescents' experiences of sexual and reproductive health services impacted by COVID-19? And what are potential policy and program solutions to address and enhance adolescent sexual and reproductive health and rights? So phase one of the study was a more traditional design. So this was a population-based repeated cross-sectional study that analyzed health administrative data for all female adolescents ages 12 to 19 residing in Ontario and eligible for OHIP during the pre-pandemic, so January 1st, 2018 through February 28th, 2020, and the post-pandemic onset, so March 1st, 2020 through September 30th, 2021 periods. The primary outcome for these analyses was adolescent pregnancy, and secondary outcomes were encounters for contraceptive management, uptake of prescription contraception covered by OHIP+, and encounters for STI management. And I'm going to very briefly summarize the key findings. There is a manuscript currently under review, so stay tuned. But just to give you a sneak peek, our findings are shown here. So the solid line is the observed rates, and the hashed line is the expected rates, and this is a graph for pregnancy. So we found lower than expected population level rates for adolescent pregnancy, healthcare encounters for contraceptive management, and healthcare encounters for STI management during the COVID-19 period. It's important to note that sexual health-related visits had not returned to pre-pandemic levels by the end of the study period, which raises concerns for ongoing barriers in access to care for adolescents. And we also importantly found that the pandemic had significantly less impact on sexual and reproductive health outcomes among adolescents who had higher pre-pandemic rates of certain of those health outcomes. So for example, among adolescent groups that had higher pre-pandemic rates of pregnancy, for example, the COVID-19 pandemic did not reduce those rates as significantly as it did among populations who were at lower risk of pregnancy prior to the pandemic. And this was true for adolescents living in low-income contexts, in rural settings, and in Northern Ontario. And this again raises concerns around the potential for COVID-19 to have exacerbated pre-existing inequities. We also used the data from phase 1 to inform our selection of regions for phase 2. So on this forest plot, the line at 1 would indicate there's no effect of the pandemic on pregnancy rates. To the left of the line means that the pandemic was associated with lower pregnancy rates, and to the right would mean that the pandemic was associated with higher rates of pregnancy. And you can see here that there were 3 regions, Central South Ontario, Northern Ontario, and Southwest Ontario, for which the pandemic really did not lower rates of pregnancy amongst adolescents as significantly. And these were therefore the regions that we targeted for phase 2 of our project. So what was phase 2? So phase 2 was a youth-led participatory action research project. So youth-led participatory action research is a research methodology that takes a collaborative approach and recognizes young people as experts to generate knowledge. It endeavors to empower youth through knowledge co-construction with the ultimate goal of catalyzing action to improve youth health and well-being. Our YPAR process involved recruiting 4 youth researchers from the 3 target regions I just mentioned, and I've included the ages of those researchers here for your reference. All of the youth researchers participated in a paid training program with experienced adult researchers. During that training, each team identified key adolescent sexual and reproductive health and rights issues in their communities and developed a related research question. They then determined and implemented a study design, including being involved in data collection, analysis, and interpretation. And then they use these results to develop solutions and share the results with their community members. So just to give a bit of a snapshot of what the training program looked like, on days 1 and 2 of our YPAR training, we discussed the state of sexual and reproductive health and rights provincially, federally, and internationally. We explored the impact of COVID-19 on sexual and reproductive health and rights. We introduced these researchers to the youth-led participatory action research methodology. We explored research as a tool for change. We discussed youth leadership and community organizing. We engaged in a number of team decision-making processes, and we explored concepts of identity and intersectionality. On days 3 through 5 of the training program, we identified community issues and assets. We collectively defined research questions amongst each group. There was a process of hypothesis development. There were a number of opportunities for personal reflections on the topic of interest. We explored and taught research methods in details, including the methods listed here on this slide. We discussed research bias and ethics, and this all culminated in developing a research plan. So that training program took place in November of 2021, and over the subsequent 6.5 months through June of 2022, the youth led their research projects. They were paid for the duration of the project. Each youth research team was mentored by 4 experienced researchers, so 2 adult research mentors, the principal investigator, and the project coordinator. The youth researchers met weekly with at least 1 adult research mentor. The adolescent researchers implemented and completely led their projects. They conducted the data collection and the data analysis themselves with support from the mentors, and they developed policy solutions based on their findings. And then we capped all of this off with a knowledge mobilization retreat, during which we talked about identifying and reaching key stakeholders and worked on preparing an academic talk. And so with that, I'm going to invite our first set of youth researchers to present that academic talk. So just give me a moment while I share the screen. All right, can you see my screen, the slides?
Yes, I can see your screen and slides.
Wonderful. Okay, so I will hand it over to team 1.
Hello, everyone, and welcome to our presentation on how COVID-19 is affecting the sexualities of assigned female at birth youth in our community. Next slide, please. So here are some of the things we're going to be going over today. You're going to be meeting our team, as well as we're going to be going over our background and context, our objectives, our methods, the results and interpretations, as well as some recommendations and our conclusion. Next slide, please. So here's our team. Sia Dalal is here, so please say hi, Sia.
Hi, my name is Sia Dalal. I'm a grade 12 student at London Central Secondary School.
Hi there, my name is Morgan Little. I'm a first-year theater student at York University. My pronouns are she, her. As well, we have Mia Polikovic, who is a first-year neuroscience student at Dalhousie University, and their pronouns are she, her, as well as Ingrid Kwong, who is a first-year health science student at McMaster University, and they also go by she, her. We are also between the ages of 17 to 18. Next slide, please.
Firstly, for some background and context for our project, we decided to research this topic because we noticed that our communities had AFAB youth that already faced difficulties with sexual health, and COVID-19 was just furthering the impact on them. There are challenges in accessibility, their willingness to receive health care, and issues related specifically to COVID-19. We also wanted to ensure that vulnerable youth felt heard and respected. We felt that there needed to be change in attitudes and behaviors in the healthcare system towards youth's sexual and reproductive health.
Next slide, please. So our objectives. Our objectives were to identify the issues that AFAB youth between the ages of 13 to 21 in our community faced regarding sexual and reproductive health. Our goal was also to inform others of our findings. Prior to this study, there really wasn't much information out there on what our issues were, and we hope to identify these. Next slide, please.
The method we used to identify these issues were surveys. We surveyed the youth population of London, Ontario on topics relating to accessibilities and barriers to sexual and reproductive health care, willingness and avoidance in reaching out to healthcare providers, and the impact on COVID-19 on sexual and reproductive health access. Participants were provided with a $5 gift card for their participation.
Next slide, please. So results and interpretation. In total, we received 58 completed online surveys. Each of the 58 completed surveys were 33% or more complete. We also received 13 incomplete responses, and we identified these as incomplete responses if they were less than 33% complete. As well, we did not include these in our data conclusions. Next slide, please.
The youth's willingness to reach out to healthcare providers was a topic we wanted to research more deeply. So we posed the question of, have you ever gone to a family doctor, gynecologist, or other healthcare provider for sexual health needs? The responses to this question were that 65.5% of AFAB youth had never gone to a family doctor, gynecologist, or other healthcare provider for their sexual health needs, which tells us that they are lacking in knowledge and experience in healthcare.
Next slide, please. Another topic or another question that we posed in regards to the topic of willingness to reach out to healthcare providers was fear of judgment. Our question was, have you ever avoided healthcare for sexual health needs due to fear of judgment from a healthcare provider? Over 50% of youth answered yes. Youth do not feel safe emotionally, mentally, or otherwise with their healthcare provider, which means they may not choose to seek help or info. This is quite dangerous and a shocking statistic. Next slide, please.
Accessibility with COVID-19 in terms of sexual and reproductive health was also another topic. So we also posed the question of how would you say accessibility to products relating to your sexual health has been in the last 2 years? The color breakdown shows how different age groups of youth responded to this question. From this bar graph, it is evident that it has been either just as difficult or even more difficult to have access to products to help with sexual health. So this is showing that COVID-19 has worsened the impact for many that may have already been struggling to have access to products. Next slide, please.
Accessibility continued. Another question that we posed in relation to accessibility was, do you feel that treatment for sexual health, i.e. birth control, STI/STD testing, vaginal pain, and more, or health in general has been difficult to access due to COVID-19? 22.4% of respondents indicated that they had experienced difficulty receiving treatment, and 27.6% somewhat agreed. This resulted in a 50% of survey takers expressing accessibility issues due to COVID-19. Next slide, please.
Hesitation towards healthcare was also a major topic. A question we posed was, I reach out for help or info regarding my sexual health when I need it. More than 30% responded disagree or somewhat disagree. This indicates a hesitation to seek assistance of any kind when one is faced with an issue regarding their sexual health. Further questions show that this might be related to fear of judgment or accessibility to information and resources. Next slide,
please. Recommendations. So our research suggests that healthcare providers should partake in additional training on how to provide care/services to adolescents in an unbiased and non-judgmental way. We also suggest that our findings encourage healthcare providers to be mindful of the impact that their words have on patients in order to ensure that patients feel comfortable/have a positive experience. It is important to instill these positive experiences early on in youth's sexual experience lives in regards to their medical experiences, because if individuals have negative experiences, this can prevent them from going and receiving healthcare further in their lives. Next slide, please.
A brief summary of what we went over is, in our project, we identified the issues affecting our community regarding sexual health. We did this by surveying the youth population of London to identify the issues in the community. The results mean that AFAB youth in our community are not feeling taken seriously in medical settings when it comes to sexual health. We suggest that medical professionals and service providers need to take measures to the youth.
And that is the end of our presentation. We thank you very much for listening to it, and we hope that you take some of what we said into consideration. Thank you very much for your time.
Thank you.
Wonderful. Thank you, Team 1, for that fantastic presentation. We have about 5 minutes for questions. If anyone has a question that they would like to ask of Sia or Morgan on behalf of the Team 1 researchers. I see Natricia.
Hello, thank you. You can hear me?
Yes, we can hear you.
Thanks so much for that presentation and well done. Happy to see a group of young researchers getting into this. I just wanted to ask, did you happen to do any comparison with other groups of youth so you can tease out whether these responses were specific to AFAB youth or just youth in general?
So what we did was I would say our research is quite specific. We mostly just surveyed assigned female at birth youth in our community. And so our research is specific to that as opposed to generalized youth.
Sia or Morgan, do you want to talk a little bit about your initial, like the populations you were initially interested in maybe, and then what sort of how that evolved?
Yeah, I'd be happy to talk about that. So initially, we hoped to research how COVID-19 was affecting the sexualities of assigned female at birth youth experiencing homelessness. And then we realized that was far too niche of a topic to research, and we weren't going to get qualitative, decent data that we could work with. So we decided to pivot our topic and just explore how COVID-19 was affecting the sexual experiences of assigned female at birth youth in our community. And that's kind of how our topic has changed a little bit through the course of our research.
Elena?
And it was also during COVID, so it was hard to.
Yes.
Yeah, it was hard to get out there and research. Yes, sorry, Elena.
Hi, everyone. Thanks so much for your presentation. It was really great. I was wondering if you could share a bit more about how you recruited people to fill out the survey and if you encountered any challenges in that, because I know I did research during the pandemic as well, and it was tricky sometimes to get people kind of involved. So.
Yeah, so we decided to conduct our research using surveys. We used a website, like a software called RedCap, and basically we kind of posted a link to our survey on social media. We also posted posters around our school and kind of talked to people in our community, and we sent surveys out to individuals and had our friends kind of network a little bit and send the poster around a bit. And we did face a little bit of problems with recruitment, especially within the first couple of weeks. I think we only had one response. And then we decided, okay, we're going to try and push a little bit more. And we put a little bit more effort into our promotion of our research and distribution of our posters. And then eventually we started getting more responses. I hope that answers your question.
Yeah, thank you.
Any other questions for group one? Okay. Thank you so much, Sia and Morgan, for that fantastic presentation. We are going to shift to group two. So give me a moment to share that screen. All right, take it away, group two.
Hello and welcome everyone to our presentation. Today we will be sharing our research project on youth's experiences with sexual education. Slide.
So my name's Angela. I'm 20 years old and I'm currently in my third year of undergraduate studies at Brock, and I'm one of the researchers.
Hello, my name is Ajwa. I'm 19 years old currently, and I'm at my second year undergraduate studies at Brock.
Hi guys, my name is Mohlil and I am a first year student at McMaster University and I'm 18 years old.
And hi everyone, my name is Madeline. I'm 20 years old and I'm in my third year of undergrad at McMaster University. Slide. So in our presentation, we will be discussing the following: the background of our project, the objective of our project, the research methods we employed, the results we found, an analysis of our findings, and finally, some policy recommendations we have for key stakeholders.
Slide. So the question we researched was, how do intersectional identities influence experiences of school-delivered sex education among youth living in Hamilton, Niagara Falls districts? Slide. So one of the reasons why we chose sex ed as a topic was because of the gaps in content and curriculum. We as a group noticed that there were many gaps in our own sex education, and a lot of important topics were missing from our sex ed, and many of the students that we interviewed felt the same way. There are also many other crucial subtopics under sexual education, such as consent, healthy relationships, safety, and many more that not only youth, but everyone should be educated on. Another important reason was the inconsistency in the content and sex ed. So many students were not being taught the same content despite being a part of the same like province, school board, or even sometimes at the same school. Slide. So we conducted this study on students aged 13 to 18 years old who received sex education in Hamilton, Niagara Falls region. The study was conducted to understand the diversity among youth and how individual identities relate to their experiences with sexual education. This research outlines the wants and needs students have with regard to sexual education and several recommendations they provided. Slide.
So the purpose of our study was to better understand young people's experiences with the current sexual education curriculum taught in Ontario schools. We decided to conduct this study in order to grasp the influences of intersectional identities on youth perceptions of sexual education, as well as to explore their lived experiences from a different perspective. The criteria for our study included that students be aged 13 to 18 years old, were living in the Hamilton or Niagara region, had completed one high school health or sexual education class, or were in the process of completing one. We conducted 8 semi-structured interviews and had a total of 8 adolescents, 5 females and 3 males, varying in ethnicity, race, and religion. Our interviews ranged from 40 minutes to 1 hour and were audio recorded and transcribed for data analysis. The transcripts were coded for patterns and themes were developed. The study was interpreted through quote extraction completed by all of our researchers. Slide.
Based on the interviews our research team conducted, we were able to identify 3 major themes, which we'll follow through in the next slides. Slide. So theme 1 was driven by participants sharing that their unique identities weren't ever accounted for in their sexual educational experiences. This involved a lack of consideration of different religions, cultures, backgrounds, and sexuality, which ultimately led to differences in how sexual education was both perceived and understood. A participant shared and stated, I definitely think that we should have learned more about the different cultures. I remember I had a friend in grade 7 who was Tamil, and they celebrate once a girl gets her period. It was interesting and cool to me. Based on theme 1, as one participant showcased that different cultures, such as the Tamil culture, had a different outlook on periods, and how learning about different cultural understandings of these concepts would allow growth and shared ideas. Slide. Theme 2 was focused on participants felt that their adolescence involved changing experiences, where as you age, you continue to develop autonomy over your experiences. Participants communicated that there's a need of acknowledging these changes in order to shape future curriculum. As a participant shared, I definitely think it should be mandatory, because the older you get, the more you grow. It's just better to learn these concepts in general. Theme 2, as exemplified by a participant, was the need to learn more about sexual education beyond the grade 9 standard, as a person's experiences evolve and grow. Slide. The last theme was based from participants describing a desire to delve deeper into concepts and identify major gaps in content. Participants felt that there was a lack of learning about healthy relationships, consent, safe experiences, and for future improvement of sexual educational courses, these concepts should be taught to be a normal part of life. As a participant stated, I feel like, yeah, they provide a basic understanding of, is this something I want to do or not? But I feel like they don't give enough encouragement on things yourself or waiting to have your own experiences to really think about if there's something you want to do in life. I feel like teachers portray sex and stuff like a bad thing. If you're not planning on having kids, then it's just like evil. They don't like teach you how sex can be beneficial to you, like mentally and emotionally. Theme 3 was illustrated by a participant who shared how they never felt supported in having experiences related to sex and how it was shown in a negative light instead of the benefits. Slide.
Overall, based on their assessment of personal knowledge and assessment of teaching and curriculum, adolescents reported that the current sexual education curriculum is insufficient and unsatisfactory. Slide. Adolescents communicated that there is both a need and want for significant changes to be made to the curriculum and provided variable recommendations, all with an emphasis on sexual education structure and content. So many commented on the format of the sexual education class, including the physical format. Some adolescents expressed a preference for the classes being divided by the identified gender of students, and others shared a preference for co-ed classes. The preference for co-ed classes stemmed from wanting each student to learn the same content to foster a greater understanding of the experiences of their peers and future partners. Many also shared that they believe it is most beneficial for students to have the option to choose between divided or co-ed classes based on each student's personal comfort levels. Study participants also commented on the duration and timing of sexual education courses. An emphasis was placed on this idea as all participants stated that sexual education should be continued past grade 9 and shared a variety of opinions on when they believe sexual education courses should be taught. Some common suggestions included continuing learning throughout all of high school in regular, so for example, monthly classes, or even creating a civics and careers style course where there is an equal combination of learning health and sex ed and physical education. Students also commented on the delivery of sex ed. This included continuing some perceived strengths of current sexual education classes, such as discussion-based learning, lecture-style content, and helpful class learning activities, which could include quizzes, group or independent research presentations, and skits. Adolescents also suggested adapting the current format by implementing anonymous question boxes and providing opportunities for students to attend one-on-one discussions with their teachers if they had more detailed or private questions. Another common suggestion was having designated healthcare professionals deliver the sex ed content instead of physical education teachers. And finally, study participants outlined their concern regarding missing content from their sexual education. The content participants wish to have covered includes healthy relationships, identifying toxic relationships, sexual assault, emergency resources, sexuality and gender identity, cultural and religious identity. Participants shared their thoughts on how the lack of this knowledge in these areas impacted their learning and how gaining this knowledge would have been beneficial in circumstances that they have faced and circumstances they anticipate facing in the future. Slide.
So it is extremely important that key stakeholders such as school boards, the provincial government, and individual teachers be responsible for the quality of the sexual education curriculum. In order to ensure an improvement in the sexual education curriculum, we are hoping to find ways to further present our findings in an effort to make changes to current policy. Some specific policy recommendations my team and I suggest are introducing sexual education classes in the 9th grade and gradually building up on the basics throughout the duration of high school, redesigning the sexual education curriculum in order to better respond to the intersectional experiences of youth, identifying a range of methods that should be used to create safe spaces for learners, including external instructors, small and large group discussions, sessions based on identified gender, didactic sessions, and discussion-based sessions. It is also recommended that to include a platform for students to provide feedback to their instructors about their learning. The sexual education curriculum should be framed in the context of the skills and knowledge needed to achieve a positive, healthy, and thoroughly teaching students about sex and healthy relationships, and to prepare them for consent and prepare them for their futures.
Thank you for listening to our presentation.
All right, thank you so much, Team 2. So we will now open it up to questions from the second for any of the members of the Team 2 research team. Ashley?
Hi, thanks so much for this presentation. It's really interesting, and I'm really excited to see that you've had the opportunity to do that at such an early stage in your academic career. I'm curious a little bit about whether there was any feedback from youth about their teachers, because I know not all teachers are entirely comfortable delivering this content. So I'm curious if they had anything to say about that perspective, because I think that that's an interesting perspective unto itself, to be honest.
I can comment on this and then anybody feel free to add. Based off our interviews, I think almost every one of them mentioned something about their teachers. And from that, one of our policy recommendations was made. One of our policy recommendations that a lot of people actually mentioned was having somebody who wasn't their healthcare teacher, like their gym teacher. That's usually like the format that it is, having them teach the course because of how they felt it was uncomfortable through doing it to someone they already knew. And they also felt that sometimes there was a lack of actual understanding of what they were trying to be taught.
Great, thank you. Like I said, I think it's just such an interesting point of interface, because so much happens in that relationship. And you're right that, if it's a gym teacher, I think of my 14-year-old daughter and her gym teacher that I just had a conversation with last week, and I don't know how that dialogue would work for her very well. So I have a real, there's a real perspective in my head right now about how that would look, and that's why I'm curious.
I remember there was a participant who I interviewed specifically, and she actually had both experiences where once it was her gym teacher and once it was somebody who came from somewhere, and I hadn't ever had that. Somebody else was teaching our courses, and she was explaining to me how it was just such a completely different outlook on everything that was happening because they were more structured, like somebody who came from outside of their gym teacher, and it just made everyone feel like they were in a more professional environment.
Thanks.
Any of the other youth researchers want to comment, or any other questions from the audience? Alana?
I'll go again. This is a topic very near and dear to my heart. But I was involved in a project a few years ago where we were interviewing teachers who taught sexual health about their experiences. And it just, sort of paralleled what you're saying, that many of them felt that they did not receive adequate training to go into classrooms and teach these topics. Themselves didn't necessarily feel very comfortable teaching these topics, and that it didn't necessarily make sense to be even married to phys ed as a topic when sexual health and sexuality is related to so many broader aspects of like society and the social world and psychology and all of these other things. So I just wanted to echo that, yeah, there's that sort of the other side where it's very idiosyncratic in terms of each teacher's experience of it and how comfortable they feel as well. And my other question, I guess, is, and maybe you mentioned this and I didn't catch it, but are you presenting this, or have you presented this to anybody, at the sort of board level, or are you planning to?
We want to, yes.
Yeah, okay.